Hey, well, welcome everyone. We are so happy you guys are in attendance with us today. I wanted to go ahead and extend a welcome to all our current clients who are attending. Thank you guys for your continuous work to deliver exceptional patient care. And we want to extend a big friendly welcome to all of those who are attending one of our first webinars. We are so glad you made it. We have an awesome presentation for you today, and we are super excited to be partnered with the Crossroads Group. So just kind of an agenda for today. We are going to be running the presentation for about 30 minutes, and then we'll be following up with a Q&A. You can submit questions anytime during the webinar, and we will either be able to sneak them in and answer live, or we will wait till the end and answer all the questions then. And then for our agenda, we will start with the presentation introductions, and then we'll do a brief overview of the SyncTimes system for context, and then we will be hearing from Mark as he introduces the Crossroads Group and shares findings and insights on the patient experience and satisfaction. And then from there, Alan will dive into the benchmarking data. And after that, again, we will be wrapping up with a Q&A. We have our presenters here today, and I'm going to go ahead and let them introduce themselves. They've got some fun pictures to share with you. So yeah, go ahead and take over, Alan.
Oh, hey, thank you, Amanda, and thanks everybody for being here. Pleasure to share some thoughts, and really excited to hear from Mark. Mark and I just met, I think, officially for the first time, probably 3 or 4 months ago. But I've been aware of Crossroads and Mark and the work that they do since starting SyncTimes. Just a little introduction here. I've been working on this for about 7 years. We came out of a community health center that was a client of Crossroads, and they were looking at their patient experience data and realized, hey, there's some things that we need to address here. And SyncTimes was kind of the software technology solution that they thought would help optimize. And then over time, we're working with health centers across the country and have improved that system to also address a number of other operational needs that our health centers have. So I'm really excited to be here. This kind of introduction picture on the right, my wife and I have 3 boys, and then we just had a daughter. And we live in Utah. I've got the mountains of Utah behind me here today. And so that's just kind of introduction. As far as like hobbies, I don't think we have hobbies right now. It's really just trying to survive with the kids and the startup, and hopefully get 8 hours of sleep about once a month. And so that's kind of the life right now. But quick introduction there with the family, and excited to be joined here by Mark. So Mark, I'll let you take it away. You're joining from I think a little more fun place than Utah. If I were to just give a non-biased assessment, I think.
Yes, I'm actually in the Dominican Republic, supposed to be on vacation, but it doesn't always work out that way. But as far as hobbies, when I'm down here, I love to play beach volleyball. So that picture there was taken a couple days ago. That's me on the bottom right there, trying to run down that ball and act like I'm 20 again. So anyway, it's lots of fun. Love to be on the beach, and it's a great place to visit if you ever get a chance. Highly recommend it. Dominican Republic, over in the Punta Cana area. As far as myself, I founded Crossroads Group in 2003. Prior to that, I was doing a lot of work as a consultant in the hospital space, helping organizations improve their patient flow, a lot of what SyncTimes does, but before we had all the technology that they're bringing to the table. And I worked with a lot of patient satisfaction and experience survey data, and started working with community health centers in the early 2000s. And I saw a huge need for community health centers and other safety net providers to really measure and improve patient experience in a better way, because a lot of them were doing it themselves and not doing a very good job of that, because conducting surveys is a lot more complicated than people often realize it is. I became a TA consultant with HRSA. And while visiting a community health center up in Seattle, Washington, they asked me to help improve their measurement process. And one thing led to another, and they became our first client in 2005 for patient survey measurement in the FQHC space. And they're still a client, happy to say, about 20 years later. And we've grown since from one client in 2005 to well over 120 organizations that we provide ongoing patient experience measurement for. And I hope to integrate some of what we do with some of what SyncTimes does, because there's a lot of overlap in terms of what we do together.
Yeah, awesome. Well, thanks, Mark. I want to probably just tee off here with a little bit of introduction to SyncTimes. Hopefully that's helpful context. I think what we're really excited about today is just sharing a little bit of what we see in SyncTimes with the operational data that we track, coupled with what Crossroads sees from the experiential data. And the hope is that people come away from this conversation having just a little bit more insight into how those two things work together, how operations and how the experience that patients have can kind of play together, and how we can optimize those things in community health. So just by way of kind of introduction to SyncTimes, we provide a system that allows health centers to eliminate chaos, improve efficiencies, and overall get a lot more information and data about what's happening in the health center. And so what we found is that most of our health centers, when a patient gets into an exam room, that often is the end of when we really know what's happening throughout the course of their visit. We don't often have good data about what's happening during their visit, how much time they're spending with provider, how long they're with nursing staff or with a medical assistant, how long they're alone in the exam room. And what we end up doing is kind of making guesses on things like, are patients spending an hour in the clinic because they're getting a lot of value, or are they spending an hour because we don't have good processes? Sometimes we end up guessing on things like exam room utilization, how many exam rooms we need to provide each provider, how many support staff each provider should have to optimize for efficiencies and for patient experiences. And so a lot of this operational data ends up kind of missing, and we end up making, I call it, poorly educated guesses on these things. The way the system works, we put tablets inside and outside of the exam rooms. These show where people are throughout the clinic, so where patients are, where providers and medical assistants are. On those tablets in the exam room, staff can communicate if they need something, and then it also shows how long the patient's been in the clinic and what stage of the workflow they're currently in. So as we look at exam 4, this tablet would be outside the door, and you would see that the provider's been in the room for 11 minutes, and the provider has requested a blood draw, some labs, and then after that this patient is done, and the provider is still wrapping up their visit with that patient. Staff wear what we call beacons or badges, and these have really two purposes. One is as people walk in, it automatically tracks where they are, which patients they're with, but then it also allows them to hit a button if they have some sort of emergency, safety or patient health incident that they need support with. And so the idea is that they're wearing this on their body and they can quickly indicate that they need help, and then that communicates out to what we call a flow station, which would be at your nurse station showing what's going on throughout the clinic. Really, this becomes kind of air traffic control to see where are patients at in their visit, what are they waiting for, where are staff, what do they need, and hopefully optimize for a more efficient workflow. That's just kind of a quick introduction to the actual workflow system. Obviously, then we collect a lot of data, and we're going to talk more about this today on what's going on in the clinic. How productive are we? What are patients doing with their time? Are they just wasting their time, or are they using that to full benefit? And then we also provide a lot of information about kind of the utilization of both staff and facilities and equipment. And so that's a little kind of introduction to SyncTimes. I think the bulk here, what we want to hear from Mark is some of the data and information that he's been able to kind of assimilate and learn over the years with Crossroads. And I'm really just excited to be here. Mark, I'm going to turn it to you. I'll probably interrupt you with some questions as we go, just mostly out of personal interest. This is probably not it's not super well scripted. Mark and I thought it would be better just to have a more organic conversation. So I'll pass it to you and just let me know if I'm not moving slides along quick enough.
Yeah, absolutely. As I've learned about SyncTimes and what they do, coming from a process improvement consulting background in healthcare, and then measuring the patient experience, I've come to really appreciate how important what they do is from a patient experience standpoint, because we collect survey data from hundreds of thousands of patients every year. We do so by telephone, we do electronic surveys, texts, QR codes, mail surveys, you name it. We collect data every which way. And the importance of that wait time it cannot be understated. You know, it's absolutely critical for patient flow. Patients get very frustrated when they're waiting, especially if staff don't communicate with them. And if staff are not in sync, if staff don't know where those patients are or where their other staff members are, at what point in the process, a lot of that is very disruptive to the flow of patients, which has implications beyond even the patient experience. It has obviously operational and efficiency impact as well. So we can go to the next slide. Just a little bit about us, just to reiterate, we've been doing this for quite some time as far as patient experience. We specialize in safety net providers, mainly federally qualified health centers, over 21 years of experience. Prior to that, as I mentioned, I worked a lot with hospitals on the patient experience side, and we've been certified by NCQA multiple times for both the PCMH CAP survey, CG CAP survey, and more recently, the health plan CAP survey. We're working with health plans as well. We've got over 95% loyalty with our clients. That's what's enabled us to continue to grow. Most of our growth has been through word of mouth. In fact, Alan and I work with some of the same clients out west, and we've got great relationships with those organizations for many years. We're currently working with over 120 health centers, community health centers, as I mentioned, representing literally hundreds, if not thousands, of delivery sites and providers in 27 states. And our reporting is really designed for two big picture purposes. One is to give leadership a view of how the organization is doing, not only in the macro, but by department, by individual provider. Our sampling method ensures that each of the providers gets an equivalent randomized sample size so they can be compared across providers and specialties and sites. And we have a lot of very actionable tools that really help management to identify root causes of both high satisfaction when things are going well, why, what are the key drivers, what's moving up, what's moving down, so that these can be very actionable reports as well. And there's just a couple of our clients represented there with some testimonials or comments from those clients. Go to the next slide. So what makes our process unique? We are one of the only survey vendors that incorporates phone surveys in our sampling methodology. Most of the other vendors out there, including Press Ganey, you've probably heard of them, they're the largest in the country. They tend to only use electronic and mail surveys. And then the other vendors don't, very few of them conduct phone surveys. And why is that important? That's important for a number of reasons. One is that the telephone survey is the most inclusive methodology. We're able to reach every patient regardless of their ability to read or their technological proficiency. For example, migrant workers, Alan and I met at a migrant health conference. And so we were working with most of the organizations at that conference because they know that to reach those patients, the only way to do so effectively is by phone. Having said that, we also can integrate electronic modes, and that's important because, again, we can reach all patients. We get a lot of comments as well when we talk to people versus sending them a text message. We like to contact patients very, very quickly after the visit. And we set targets. Another thing that differentiates us is that we have basically guaranteed sample sizes for each provider, each location, each department, organizationally. So we define the project in terms of random completed surveys rather than attempted surveys. Like most vendors will say, we're going to send out 1,000 email messages, or we're going to email every patient after the visit. That's very easy to do. Much harder to do is to actually break out that completed survey sample and define the project up front, and only invoice, by the way, for those completed surveys. Everything is randomized, or it's a full population survey. We get confidence levels within plus or minus 5% for each of the sites per year. Everything is delivered real time as far as reporting. And then we have a report package that usually goes out every quarter. And we emphasize in our reporting, we don't have time to go over all of that, but if anyone wants to reach out to me later, I'd be happy to walk you through some demo reports. We give a lot of attention to a lot of the things that SyncTimes is addressing. So coordination of care, for example, is a big one. And patients, that's a PCMH measure, by the way, and it's also a key critical ingredient for patient experience. You know, if patients feel that the staff are not in sync with one another, no pun there, they recognize that. They know when the left hand and the right hand are not working together, or when they're getting repeatedly asked the same questions by different staff during the same visit. Very frustrating. It delays the visit. It's not efficient. It adds to the wait time. Patients don't like to be in an exam room alone, waiting for a provider that doesn't show up for 20 minutes. So all those are things we pick up on the patient survey. So we know the importance of those things, and we report on those at the location, provider, and department level, supplemented with detailed comments. And our surveys focus both on satisfaction and experience. Both are important. The difference between the two is a little nuanced, but basically the experience is, did this happen, yes or no? Or how often did this happen over a course of time? And then also important, how did you feel about that experience in terms of your satisfaction? And we measure both of those aspects. They're both important for different reasons. And next slide. I won't spend too much time here, only to say that we look also at the correlation between some of the questions we ask and the overall rating. And what we find is that quality of care almost invariably is the highest correlator. And we see that here. It's the correlation scales on the x-axis on the bottom. We see that circle there to the right. And we see that with almost every client. You know, the quality of care is the key driver. It's the reason why they go for healthcare, right? So you could have the nicest staff in the world, but if the quality of the care is not good, you know, your visit is kind of a waste of time. So what SyncTimes does is, again, as I've gotten to know what they do, I see the value in it, because what they do is ultimately have a huge impact in that quality of care because of that coordination aspect of everyone knows where everyone is, and they can maximize the value added to that patient during that visit in the shortest amount of time possible. And that has a direct impact on that quality of care perception, but also that provider explanation of care, which is another key driver, the provider listening, knowledge of health history, also a hugely important variable. The time spent by the provider, the perception, not only of the minutes spent, but the quality of those minutes that are spent. All of those are key drivers of patient experience, and that is backed up by hundreds of thousands of surveys that we have in our database. We'll go on to the next.
Yeah, real quick, Mark.
Yeah.
I'm just curious, when you have health centers, let's just say that, you know, this quality of care measure is lower than the health center wants it to be. What are the levers that they're pulling? What are the things like, you know, I think when a lot of the people on the call today think quality, what we think of is quality scores, and there's measures we use to track that. I'm guessing that when a patient receives this question in a phone survey, maybe they don't think about it the exact same way. So what are some of the ways you see people driving that point up for patients, or improving their quality of care that patients are reporting?
Yeah, that's a great question. I think sometimes what I've seen over the years, been doing this for 25 years or more, sometimes staff and patients define quality in different ways. Sometimes nurses define quality as the quality of that blood draw, you know, in terms of the phlebotomy, or the quality of the diagnosis, or the quality of the medical care. And that is part of the quality of care for the patient, but quality is defined more broadly by patients. Patients are not always able to identify quality from a clinical standpoint, but they are able to determine whether or not someone was friendly to them, or someone communicated with them, or someone explained care. So simple things like just greeting a patient, introducing yourself, and explaining what you're doing. We call it GIE acronym. Greet, introduce. It's a short version of AID-IT for those familiar. You know, that's how most patients define quality. Now, some are a little more sophisticated. They might have a little more background in medical care, but I've heard staff tell me face to face in hospital settings, I'm not here to be nice, I'm here to save the patient's life. I've literally had staff, and I cringe inside when I hear that, because they're not mutually exclusive. You can do both. You can deliver quality care, and if you do so, there's research that actually shows that if the patient satisfaction is higher, clinical outcomes are also higher as well, because there's a higher degree of engagement with the provider in that patient interaction. So,
Yeah, that's interesting. I was just thinking about like how would I answer that question for my child's pediatrician, as an example. And I'm not clinically, I'm maybe a WebMD cowboy would be a good way of saying, I know a little bit what I can Google, but really I think for me a lot of it is like you said, how people treat me, how things are explained. I think also there's just a feeling when you walk into a facility. Is the facility clean? I think there's a lot of things like that play into it. And then also, you mentioned, are they asking me the same thing over and over and over again? If I feel or if I perceive that people do not remember me, or that, the systems are not in place, then I'm going to perceive a lower quality, even though, I may have the most excellent, technically proficient provider that's providing theoretically the best care that exists this side of the Mississippi, right? It's just I think there's an interesting perception there that is important and challenging, I think, to drive. It's really total quality management.
I'll share just really quickly a story. I dislocated my finger in Florida one time, and it was completely dislocated. I was in immense
volleyball
pain.
or
No.
no? Okay.
No. I just I fell on a step, and landed all my weight landed on the finger, and it was completely dislocated. I was in such incredible pain. I went to the closest ER, walked in the front door. The reception greeting was so horrifically terrible from a service standpoint that I literally walked out of the ER and went to an urgent care center a few miles away, because my first impression was so bad about that facility that I didn't want to risk staying, even with the amount of pain that I was in. So it makes a difference.
Yeah, awesome. Well, thanks. I just wanted to dig into that a little bit. So
yeah, and this really quickly is the correlation coefficient for one of our clients as an example, the top 5 correlators with overall. So we're taking questions on the survey and we're identifying the correlation between the question and the overall rating. And then we also combine the satisfaction score to get a leverage value. And the higher that leverage value, that means it's a big opportunity area for improvement, because if you improve that, it's going to correlate with the overall, but it's also based on the score as an opportunity for improvement. And quality of care is coming out the highest on that leverage score. Provider knowledge of history. Again, the same things that SyncTime is really, really helping organizations. And by the way, I know this for a fact because I actually work with some of the same clients that they work with, and I've seen how those organizations rank in our benchmark. They're among the top scoring benchmark organizations. So I know based on data, empirically, that what they're doing is working from a patient experience standpoint. Provider explanation, routine appointment wait, and provider time spent. Those are some of the most important key drivers from a patient experience standpoint. And we've got benchmark data. We collect a lot of data from a lot of health centers around the country. We stratify it, medical, dental, and behavioral health. And we can see here what the lowest score in that benchmark is, as well as the highest score, as well as key thresholds in between. And nationally, provider weight, which is a key driver that we just saw, is the second lowest median score in our benchmark. So that is a pain point for a lot of patients. It tends to score low, and it's a high importance item. So anything you can do to improve that perception, it's not just the minutes on the clock, it's also the value added during those minutes. So if patients feel like they're getting value during that time, they're not going to mind spending the time. But if they're just idle minutes, like Alan said, sitting in an exam room alone, that's not value added time. That's time that's frustrating to patients. Appointment wait also tends to be a low score nationally, and you can see that as well. with that median value of 84.3. So those are really, really key areas of opportunity for a lot of health centers.
Yeah, the just kind of an anecdote that I think is interesting on this provider weight question. We had a health center as we were kind of experimenting with different things, who is a Crossroads client and said, "Hey, we want to measure this, but we know we could do some things around our processes, but initially we think it might be low-hanging fruit for us to just communicate more effectively, this is your estimated weight." And so they put that in the waiting rooms. We do that in SyncTimes, but we just did this manually to test it. And then they also just trained staff that when the medical assistant finished the intake process, he or she would just share with the patient, "Hey, it'll probably be about 20 minutes. You have 2 patients ahead of you." And it was interesting because their door-to-door cycle times did not change. And, we're fairly confident the provider wait time did not change, but the scores went up significantly. And so to your point, sometimes it's just the communication on these things and being able to give your staff the data they need to then communicate more meaningfully with patients. Allows for patients to just feel more at ease, like, hey, at least they know what's going on in their practice, right? They're not just making me wait because they don't care about me, right?
And your system has a way to alert the staff that there is a patient who's waiting more than X amount of days, correct?
Yeah. And so that's something we've added in. What we realized is that what really annoys patients is not just their total wait time, it's the time between touches, where maybe they're 30 minutes after they see the MA when the provider comes in. So if we can just make sure there's a touch point between that recognizes, hey, you've had a wait and we need, and your provider is coming, we're just seeing other people, that really drives an improvement for the patient's perception of that wait.
And here's more benchmark data, but this is experiential, meaning this is the percentage of respondents that said yes to these questions. And nationally, the percentage of patients that said they saw their provider within 15 minutes of their scheduled time was 88.4% in the second quarter. But there's a wide range of scores ranging from 70% all the way up to 96%. And CBHA and CBCH, these are 2 organizations that SyncTimes works with and we work with. And as I mentioned earlier, these tend to score highest in our benchmark. This correlates the actual experience with satisfaction, and suffice it to say that if the patient waits 15 minutes or less to see a provider, they're pretty forgiving. You can see the mean satisfaction scores with the blue bar is 90.2 or 94.1, so above 90 on the mean. But once they wait over 15 minutes, look how fast that drops, all the way down to 83.8 with just a 5-minute increase in wait. And then if they wait more than 20 minutes to 30 minutes, it drops even more down to 78.7. And after 30 minutes, you're basically done from a patient satisfaction standpoint, with scores dropping down to 68. That's like a D in school, basically. And then after an hour, you might as well just call it, because it's going to be pretty abysmal from a satisfaction standpoint.
And if I'm reading this right, it's basically up to 20 minutes captures about half, plus or minus,
Yes.
of patients. Is that right?
Yes, exactly. Yep,
Cool.
that's right.
Yeah, I'll be interested. We're going to look at some numbers on that. And so it'll be interesting to correlate, because this is like patient reported time. And then I think it actually correlates pretty well with reality there. So.
And I'm not going to read all these for the sake of time, but I just to make the point, when we go through the comments that patients make, so many of these comments that we read, I would say up to half or more, are dealing with weight. Because this is, again, it's a key driver. We see that from the quantitative side, but we also see it on the qualitative side. People talk about what's most important to them. And when we call them and conduct an interview, many times what they want to talk about is either the communication with the staff, the quality of that communication, or how long they had to wait either to get that appointment or once they arrived. And if they had a point in time where between touches, like Alan said, that they're waiting too long based on their expectations, you know, that's a real important aspect of their visit and will emerge in these themes as far as narratives.
Yeah, I like this one here that I waited and it's not fair, right? There's an element here of kind of justice or kind of a health equity element that I think ends up playing into it. It's interesting.
And related to that, if they made an appointment and they waited 3 weeks for that appointment, they're going to feel that
Yeah.
that's not fair because they made that appointment, and with that appointment comes an expectation that they're seeing quickly. That's why they're waiting for that appointment.
Yeah, that's cool. I think this is just going back to this real quick. This is something I think is really cool about Crossroads. I think most of our health centers have some sort of, I think all of them have some sort of surveying they're doing. But I like the depth of data that Crossroads is able to get because it's a phone call and it's a conversation with a human being about your experience. And I think that's so powerful because, at the end of me hitting that submit on Google, maybe the health center could reach out and try to do a follow-up to dig deeper. But you're only going to do that probably in edge cases, right? You're only going to do that for patients that either say I had the greatest experience of my life. It was better than my birthday. Or you're going to have patients that said, hey, this was terrible. There was some, horrible grievance that they were trying to file through their satisfaction survey. So you miss all this nuance in the middle of patients who say like, yeah, it was a 6 out of 10. And this is why, and this is how, if you want me to love the health center, here's those nuances that need to be improved. And I think it's really, telling when you read some of these statements and you have access to this type of data. It's a lot more than just, well, they gave us a 6 out of 10, right? There's a lot more information to be gathered here.
Very good point.
Yeah, cool. Well, I just want to share a couple of things from our 2024 operations benchmark report. This is actually from calendar year 2023. So this data is a little bit outdated. It's basically 20 community health centers or 22 community health centers. And it's taking essentially a look at a typical patient visit at different quartiles. So just to give you an idea, what we want to do is kind of walk through a visit and give you just really some of the quantitative data that we capture on the SyncTimes side. The first one is just looking at what percentage of patients checked in for their appointments within 4 minutes of their appointment time. And what we hear often on this is this kind of anecdote in healthcare that, hey, patients are most of our patients are late, therefore we're really, we really struggle to run on time. What we see on average is, yes, absolutely, there are patients that are late. The lowest performing health center on this mark, it's around 50% of their patients that are running late for their appointments. Not coincidentally, that is a health center where their wait times tend to be longer, right? And so a patient hears, I've got a 3 o'clock appointment, and they know that doesn't really mean that they have a 3 o'clock appointment. And so you see, our median health center, 3 of 4 patients are arriving within 5 minutes of their appointment time. And that arrival is often just skewed a little bit more towards patient being on ride than I think perception. Then we look at, what is the time in the lobby? This is going to be skewed probably towards higher performers, in part because these are people using SyncTimes, capturing this data and acting on it. But median here is about 10 minutes, and you can see there's kind of a long tail where you have some organizations where they have really, quite long wait times in the lobby, but that, top half is really doing that in under 9 minutes, which I would say is a high bar. I think if you go into your average community health center and you just kind of ask patients in the lobby how long they've been there, you're going to have relatively few health centers where they're doing that, in less than 10 minutes. That's a pretty good bar. And that's part of what I think just having that communication and visibility has allowed some of our health centers to do. And we look at when the medical assistant comes into the room, how long are they spending? We see kind of vast variety here in what health centers are expecting from medical assistants. And so some health centers, they really have the MA just do a very basic intake process, and then the provider picks up the rest of that process and really ends up probably not working top of license as a result of that. And then we have others where the medical assistant is really responsible for a very robust intake process, leaving relatively little for the provider to pick up on, and most of it is well documented and well trained. We also see in some health centers this is not done consistently across the board, meaning some medical assistants and some providers will have, say, a 5-minute intake process, and others it'll be 11 minutes. And what you have there is just a process disparity where you don't have consistent processes across your organization, which is usually an opportunity to really standardize, really optimize for the quality outcomes that you want for your organization. The challenge in that comes if you ever have a provider call out and an MA is floating over to support another provider, then all of a sudden they're trying to learn someone else's workflows, and you end up with challenges and frustrations there because you're not standardized even within a single site, let alone across an organization. This alone minutes is looking at how long are patients spending alone in the exam room. This is something we've kind of coined because we realized that this drove patients' perception of their weight more than the actual time that they were in the lobby was the time that they were in the exam room. And you think about that, it kind of makes sense quickly in that in the lobby, there's at least people coming and going, there's movement, there's things to observe, there's probably a magazine around. When you're in an exam room, you hear footsteps outside the hallway, but really you're kind of in solitary confinement in that exam room, waiting for someone to come in. This is measuring, the reason I mentioned that 20-minute thing earlier, that about 50% of patients reported a 20-minute. I think these are different measures. That was time to provider or wait for provider. This is aggregate time alone in the exam room, of which about 60% is usually waiting for provider, 40% is after the provider has finished. But it still is around that 20-minute mark where patients are alone in an exam room, really just taking up space for about 20 minutes on average throughout the course of their visits. Of that, I mentioned that 60% numbers, that would be 12 minutes. It's 11.6 here is that time that they're waiting for the provider in the exam room. Again, part of, I think, that perception being longer is that health centers that are really measuring this at this level tend to, I think, perform a little better on this measure. That already, staff time that medical assistants or support staff are with patients, again, wide variety here depending on the expectations of the health center and the providers of their medical assistants. And then provider minutes, this is one that, Mark, you mentioned, a specific measure related to time with provider. And I think we've seen some interesting perceptions there, where some providers actually do not spend more time with patients, but they make that patient feel so loved, right, and cared about, and they remember things from your past conversation. And they cheat on that, right? They put notes into the EHR to say, hey, Mark's daughter just graduated high school. Remember to ask, how she's doing. But those things help patients to often perceive that provider time is really valuable and is a sufficient amount of time. We have relatively few, I think, providers where they end up spending too little and patients really key in on that if they do a great job communicating with patients and understanding and having that kind of EQ bedside manner in place. This one's probably a little unrelated to the patient experience, but just looking at exam rooms across healthcare, what we see is that on kind of the median is that 14% of the time an exam room is used from Monday to Friday, 9 to 5, meaning that 86% of the time an exam room is just sitting there empty. And so you think about, the cost per square foot. I've heard, $800 up to $2,000 that we're spending cost per square foot for an exam room. You multiply that roughly 1,000 square feet on the low end for an exam room, and you're spending 6 figures for a resource that is often sitting vacant north of 80% of the time. And so this is something that I think is less a patient experience thing and more a resource utilization question, which is how do we maximize and share exam rooms more effectively between providers? And then productivity is probably not super relevant to our conversation, but again, some significant variety here. Median of just under 2 visits per provider hour is what we end up seeing. I'm going to just jump through here. Patient cycle time, median with our health centers about 52 minutes, which again is really good. I think most organizations would say anything less than an hour is something that they are happy about. Most of our health centers are pretty quickly able to dump at least 10 minutes, but often more than that off of that cycle time, which allows them to obviously provide more services, but then also just provide that better experience for patients. I think with that, I want to just share, let's see, Amanda, I think you've got a slide. Maybe you could share contact info, but I know we had some Q&A here. So maybe Amanda, pass it to you for Q&A. Mark, any other thoughts before we go back to Q&A?
No, I thought that was fantastic. You made some really good points.
Cool. Yeah, thanks. And Amanda, you're muted. But it looked brilliant, what you were saying.
Thank
so,
you.
yeah.
Thank you. It actually was one of the smartest things I've ever said. Actually, my screen share is being kind of funky, but I'm working on it. But yeah, so one of the questions that came in, and just for everyone here, I just wanted to go ahead and encourage you guys, if there's any questions that have come up during this presentation, go ahead and throw them in the chat. We'll take a couple minutes now to answer them. The first one that has come in is, this is a question about the SyncTimes system. They're wondering, so kind of blast from the past, since the exam rooms have that wall in between them, has the beacon ever confused the location of staff?
Yeah, good question. So the way that we're capturing that, and that we're I guess using the technology we're using for that is infrared light. And so it's a little different from like Bluetooth or something that could kind of transport through walls. Meaning that if you're in an exam room, what you end up seeing is a light that pulses and shows just inside that exam room, and so it does a really good job not communicating out. So yeah, for that question, they are on a wall, but because it's line of sight, as long as you're in an exam room, it really does a really good job capturing that. We've done a lot of testing with other technologies, and infrared has been the most effective in an exam room environment.
Awesome. All right, we've got a couple more in here. All right, the next question for you is, someone says, just to be clear, are you stating the average visits per hour for a provider is 2.5?
Yeah, no, that's a great question. The short answer is the median is lower than that. So median is closer to 2 across community health. We do have health centers where they're 2.6, and we actually have a couple that are north of 3 on average. But what we see just in the aggregate in community health is that it's around 2 on the median.
Alan, just a question for me. Do you notice an improvement when you engage a client in that metric?
Yeah, it's a great question. I would say we have clients where they're prioritizing that and they're saying, yes, we need to improve that number. We also have clients where they're saying, hey, productivity is pretty good, or we just don't feel like we can ask people to improve that number. I'd say there's 2 ways to do that. One is, let's just say there's a bell curve of your providers and their productivity. Typically what we see is you can either try to move the median on the bell curve. You usually do that with your templating, right? And you say, okay, previously we were doing really 2.5 encounters per hour. We were doing 3.5 encounters per hour. We're going to move that to 4. We're going to move it up a half encounter. So that's kind of moving the whole bell curve. The other thing that we do see, probably more common now, is we see organizations where they're saying, we have providers that are on the left end of that bell curve that are performing below our expectation and our median, and we need to work on how do we get those providers up consistent with the others. We find that is often lower hanging fruit than trying to kind of move the whole mass. Usually organizations, whatever that expectation that has been set, is often a little more difficult, and not necessarily a technology thing. It's more of operations and clinicians coming together and saying, hey, this is where we feel that should be. Corey asked a question, trying to find that balance between productivity and good patient and customer service. Mark, I'd be interested in just your take on that, because I think we're all very aware that no money, no mission, right? And ultimately, part of the question is how many patients, lives are you able to touch? So I'm just curious how you see that play out in your data, and kind of how you maybe prioritize striking a balance there.
Yeah, I think it's not always necessarily about people working harder. It's more about working smarter. And I think if you're using resources in an optimal manner and you're eliminating wasted motion, then you can achieve both goals. You can improve staff. By the way, that's another thing we measure is employee engagement. And they all tend to move together. You can improve employee engagement, customer satisfaction, financial results. There's a ton of research that shows all three of those do move together quite a bit in healthcare. So it's not about making people work harder necessarily. It's just about better communication, better coordination, better utilization of time and resources. And those things combined will deliver a better patient experience as well.
Yeah. And I think one of the elements to what you just said, Mark, is if you really go and sit in a nurse station in 2024 in a community health center, what you're going to observe is a whole lot of time spent on things that just don't add value for any patient, right? Mm-hmm. And it's things like the simple one that I'm always, it's like, how long does it take before I hear the question, where is blank? Where is my provider? Where is, this person? And for us, obviously, that's, part of what our system is optimized for. What we found is there's just so much time we spend on these tasks that, in 2024, I think artificial intelligence has a huge role to play, but there's also some just technological and some leadership management problems where we just need to get into the weeds a little bit, look at these challenges and say, okay, that right there is waste. I'm calling it waste because no one's getting value out of the time that we're spending chasing down that, piece of equipment, or the time that we're spending trying to, 7 clicks in to try to get to the patient's blood pressure, right? And so I think if we really just take a surgical view, a systematic view of those things, what we often find is that, there's so much waste. And the way it's manifest is that our average provider that we see in our data is only spending 32 minutes an hour with patients, meaning 28 minutes per hour is doing things that probably are not really requisite of their license. Obviously, charting is important. Obviously, following up to emails and kind of working through their bucket, that's important. But really, I think providers want to spend time face-to-face with patients, and they're paid to diagnose and to provide treatments. And, I think we expect a lot of administrative work that hopefully we can optimize around that.
I'll never forget years ago seeing an emergency department provider pushing patients to radiology down the hall on a stretcher because there were no transporters. So hospitals paying a lot of money to that provider to push a patient down the hallway. Not good resource. Yeah.
Yeah. No, we were on a call today actually with the health center where their MA to provider ratio is 0.25. They have one medical assistant rooming patients for 4 providers. It just doesn't work. You end up with providers doing a lot of things that are way below license. Cool. Go ahead, Amanda.
Yeah, we've got a couple more. So someone said, do you have any data on patient satisfaction correlated with self-rooming versus MA escorted rooming?
Interesting. Mark, has that come up at all for you? That's something we're just starting to kind of tinker with. So I'll share some of the anecdotes we've heard, but is self-rooming ever? Yeah.
No, but that's the sort of thing. We develop a lot of content for our clients. So we have benchmark questions that are standardized and benchmarked, but every client also has their own custom, unique learning objectives, if you would. And that's the kind of question we could incorporate into a patient survey if it were needed.
Yeah. Just for reference, we are doing this with a customer in Michigan. And essentially the patients come down kind of a separate corridor. The tablet on that side flashes green on the sides and it says like, welcome Mark to your exam room. And that's been, they had seen that in some of their data, which is, probably more rudimentary in terms of how they're capturing it, but they are capturing some data. And so what we've noticed on the data side, kind of our operational data, is that the patient lobby time goes down to effectively nil, and then that alone time goes up about half the time that lobby time. So overall, their visit gets shorter. There is a little bit longer, alone time in the room, but overall it is more efficient. But the big thing is that patients perceive it as a very favorable experience. They really just appreciate kind of that concierge, like you get to your hotel and they're, yeah, hey, we're expecting you. You're going to be in 221. It takes 30 seconds, and then kind of the system all kicks off from there. So I think that's probably some of the root of that question.
All right, thank you guys. Okay, next question says, for a new health center build, have you ever been closely involved with design optimization for SyncTimes?
Yeah, so I think that's probably a question for me. And the short answer is yes, we've definitely been involved with kind of design optimization and how we're using SyncTimes in a new facility. We also have some partners that we work with that I think Boulder Associates is a build design firm that I think does a really good job with that. And so obviously not an architect, but very familiar with healthcare workflows and love to kind of help dig in on that front and maybe share some thoughts on that. So that'd be something. I put Mark's email and my email in the chat. So any follow-up questions related to that, happy to share. It looks like Corey asked a question about average support staff per provider. I just want to confirm we're looking for ways to decrease some of the work our providers have to do, increase better balance and patient experience, or recommendations related to support staff per provider ratios. Just some quick thoughts on that. It depends a little bit on your state. And just in that some states require like a certified medical assistant for certain things. Some states actually require like an RN to administer, to do some orders, some labs. So there is some dependency there on your state, your regulatory environment. But ultimately what we see is that if you have more support staff per provider, a couple of things happen. First off, your patients are going to have a little bit lower weight, so that does happen. However, it's at the cost of there's only so much time an MA is spending with a patient per hour. So if it's truly a 1-to-1 ratio and your patients, you have 2.5 patients per hour and your MA is spending 5 minutes with those patients, we're only talking about 12.5 minutes per hour that medical assistant is face-to-face with patients. And so what that means is if you do 2, that time is going to cut in half. Each MA is only spending 6 minutes per hour with patients, and then 54 minutes doing something else. So I think the expectation, and kind of how you manage that obviously depends on regulatory environment, but then also you just want to think through what are we expecting them to do in addition to just rooming patients and just working with patients. If you're just expecting them to do intake and to draw labs, I think the short answer is you can do that on a pretty slim ratio. However, if there's kind of a higher bar, if there's other things that are being expected, I think the way I would approach that is really measuring what are those other things, and then if we add, in addition, what does that take off of our provider's plate? One other thought there is that we have health centers where they'll just experiment with those things. So they'll take a high producing provider. They have all this data in SyncTimes of like, what is that provider doing with their time? What's the productivity? How long are patients alone, et cetera? And then they'll add that second medical assistant, and then they'll just see, hey, what changed? And obviously they'll add quantitative or they'll add qualitative experiential data talking to a provider. And part of the goal is how do you kind of quantify that ROI on really doubling your staffing ratio there. So those are a couple of thoughts. Mark, any other thoughts you have on that question? I think it's kind of an interesting dilemma we face in 2024 in healthcare.
No, I thought that was a good answer.
Yeah, great.
Awesome. Well, you guys have answered all the questions for today, so thank you for both of you for doing that. I just wanted to thank everyone for being here today. We really appreciate you coming. We hope this is super educational, and we would love to hear any feedback on future topics you want to hear about, so don't hesitate to reach out. After the meeting, you will receive a copy of the recording and the presentation slides for you to reference, and I'll also send out Mark and Alan's contact information so you can follow up with any questions you have as well. That's all for today. We're going to go ahead and cut y'all loose. Thank you so much for being here, and we hope to hear from you in the future as well.
Thank
Hey,
you.
thanks so much, Mark.
Yeah, my pleasure. Thank you all.